Hello everyone, welcome to SudhirEyeCoach. Our channel is dedicated to all budding ophthalmologists out there. Whether you are looking for expert insights, surgical techniques, or simply one guidance on your journey, you are in the right place. Today I'll be sharing a video where I'll be showcasing a dislocated PMMA lens and how to handle such situations, and it will be definitely very informative for fresh budding ophthalmologists. This was definitely a challenging case. A sunken PMMA with one haptic in the antechamber and the touching on the endothelium poses a significant risk of to the cornea, particularly in terms of endothelial damage. In such cases, repositioning might be an ideal if the lens and the haptic are intact, but if the haptic is broken, explantation and the fresh implantation would be necessary. So in this case, I found that haptic was intact and it was a great relief. It means that we can manage this case without explantation of the lens, because the PMMA explantation is a challenge because we have to make a larger incision either in the cornea or through the scleral tunnel incisions. Explantation of the PMMA lens is a challenge because of the size, but implantation is not very difficult in such cases. So whenever you are planning to handle such cases, you should have multi-piece lenses standby with the proper biometry and the power calculation. So ensuring that both haptics are securely positioned in the sulcus is critical to avoid future dislocation and other complications. So here I found that one haptic still over the iris in the antechamber, which can add the complexity of the case. So using the Sinskey hook, I carefully dissected and manipulated, and this is the great technique in such situations. So the iris was friable and it started bleeding, and it further adds another layer of complexity to the procedure because the visualization becomes slightly difficult. So in this situation, fill the antechamber with the viscoelastics, and then with the bimanual technique try to rotate and try to manipulate the haptics and optic and try to place the haptic in the sulcus area. So the pre-operative planning in such cases is crucial for managing dislocated IOLs. Assessing the potential for a successful repositioning helps guide your approach during surgery. If repositioning is not feasible or safe, explantation becomes necessary, and careful planning for secondary IOL implantation is required. Selection of appropriate intraocular lens is essential in such cases because we have to implant the lens in sulcus, and 3-piece hydrophobic IOL is often preferred for sulcus placement due to its stability and reduced risk of inducing inflammation and other complications like post-operative glaucoma. Thorough viscoelastic removal is indeed critical to avoid complications of raised intraocular pressure, because I have created 2 side port incisions. So here I used bimanual irrigation aspiration cannulas, and it's a good in such cases. During irrigation and aspiration, we can assess the stability of the lens and its placement in the sulcus, and it helps to ensure that the lens is properly positioned and remains stable throughout the procedure. If you have any suggestions and queries, please do comment, and I'll be very happy to answer them. Thanks for watching.